and re-enter that, this patient's ear canal entrance is completely shut. It's what we call a collapsed ear canal. Collapsed ear canals are very common in the more elderly patient, and that's because the outer third of the ear canal is made up of cartilage. And over time, as we age, a bit like the tip of our nose, which is also made up of cartilage, the cartilage weakens and then gravity takes its toll, and it can, in terms of the tip of your nose, you can get a droopy tip, and also the entrance of the ear. So think about the cartilage acting like scaffolding. The scaffolding weakens, cartilage weakens, gravity pulls the ear down, and it can cause the back part of the ear canal, the posterior part, near the entrance of the ear canal, just to collapse over, come forwards, which then creates a complete seal at times at the entrance of the ear. And you can see there, it's completely sealed, canals collapse. So what I'm having to do is stretch the ear open, and then I insert the endoscope into the ear, and I'm using the endoscope almost like a doorstop. So not only is it visualising the wax, I'm using the endoscope to keep the ear canal ajar, which then allows me to insert the instrument. You can see the Zollner suction probe. This is a standard Zollner suction probe, only just fits in the ear. There's very little wriggle room in there. I've just put some oil in there as well, and that's because this wax that the patient's got is also very mushy, it's glutinous, it's sticky, so it's very hard to suction, and it keeps blocking up the suction tube. So a bit of oil in there. So if you've been watching my videos, you know I like to make these food analogies. Olive oil acts almost like an egg in a potato cake or fish cake recipe. It binds all the ingredients together, and olive oil has a similar effect with earwax. It binds it together just like it has here, and it then enables me to remove it in large chunks. So I've just brought this to the entrance. I'm just trying to wriggle it through now. And you can see it's just blocked the tube there slightly. So again, I'm just stretching the ear open ajar, opening up the entrance a bit, and I'm just trying to squeeze the suction probe into the ear, and I'm just wriggling this out now. So it's quite a large plug. It's quite oily because I've dosed the ear with oil. So that's removed the blockage. You can see the patient's eardrum. That looks nice and healthy. The short process of the malleus. So with the malleus is the hammer bone. That's the first of the three bones, and the hammer bone is connected to the eardrum, so we can see that. At the top of the hammer bone, we get a pointed bit, almost like a ball end. That's known as the short process or the lateral process of the malleus. It's really almost like your elbow, the pointed bit. If you think about your hammer bone being very similar. So that's protruding outwards slightly. It could just be that's the way that patients' ears are, or it could also be that they've got a slight retraction, so the eardrum's sucked inwards due to negative pressure in the middle ear cavity as a result of a blocked eustachian tube. So the eustachian tube is the pressure equalizer. It equalizes the air pressure behind the eardrum to that of the atmosphere. And when the air pressure is the same either side of the eardrum, that's when the eardrum is most mobile, most compliant, that's when we hear the best. So the right ear is complete. We're just here on the left side now. So I put some drops in immediately. I'm using the endoscope here to stretch the ear to the right so we can open it up, because this ear is also quite narrow. I wouldn't say it's as narrow and as collapsed as the patient's right ear. Nonetheless, I put the endoscope into the ear, to the bottom right of the ear canal. Use the endoscope almost like a crowbar almost to stretch the ear open, which then allowed me to insert the suction probe. You can see I'm just gently wriggling these soft plugs of wax out of the ear. And I'm just trying to lift this off the bottom of the ear canal. It's slightly attached there with some skin adhesions, just to mobilise the plug, and then slowly I can wriggle it out the ear. You can see that motion going up and down, and as I'm going up and down, that's detaching the wax plug off the canal wall, and then at the same time I'm also coming away from the eardrum, so laterally, so I can extract this plug. I've got a feeling the suction probe slightly blocked there, but it's got enough suction grip. And you can see that wax starts to take the shape of the ear canal. It's almost forming like a cast. It was the patient's ear is quite narrow and a bit twisty, and that plug itself, when I extracted it, it took the shape of the ear. So the ear canal's clear. I'm just mopping up all the wet wax at the entrance. See, there's a bit of keratin on the back part of the ear canal. So this patient's ear, as I mentioned a moment ago, it's quite twisty and bendy. The eardrum veers off to the left. So most people's ears, if not everyone's ears, we've got an S-bend, and that's a protective mechanism. So our ears evolved to have this S-bend, this meander within it, and that's designed to protect the eardrum from any objects that may go into your ear, so it doesn't perforate and penetrate your eardrum. So when you've got the two bends, it makes takes these objects more difficult to come in contact with the eardrum. So I'm just using a fine end gauge here. Now, if you don't remove all this, we're not too concerned because the patients can hear again. That's the main part of earwax removal. So there's a difference between ear cleaning and earwax removal. Ear cleaning is not really practiced in the UK. I think it's more in the Far East, and that's when the ear's cleaned for almost pleasure and relaxation, and they will try and get all this wax out, which I think it's not advisable. Yeah, we can get as much out as possible without it causing any trauma to the patient and bruising or grazing the ear canal, but as long as the patient comes to a clinical ear care, especially in the UK, because they've got symptoms such as hearing loss or reduced hearing or occlusion. That's when your own internal sounds, so respiratory sounds, chewing, yawning is trapped inside your head, or tinnitus, or vertigo, or earache. And when we teach our clear wax delegates, I always preach less is more, especially when you're inexperienced and you're just starting off. So, for example, this little bit of wax on the anterior canal wall, I would typically advise my clear wax delegates just to leave that, because it's not going to cause any major disadvantage for the patient. Now, once you get a bit more skilled and you're experienced, if it's not, and again, I would myself, if I felt I was going to putting the patient at risk in any way and trying to remove that, I would not have attempted it. But when you become more confident and skilled and experienced, you're then able to remove a bit more wax. So certainly compared to my procedures when I first started endoscopic earwax removal 5-6 years ago, I can see the improvement in myself, and I'm still improving now. Although I feel like I'm very skilled at what I do, very experienced at what I do, but I'm still learning. And that's what's great about endoscopic earwax removal. I think with an endoscope, the learning curve is never complete. You can always improve your skills, your techniques. When I first started wax removal using a different visualization method, I felt I was limited and I was never going to get any better because the view I was getting with that device prevented me from doing so. So I hope you enjoyed that video. Now I'm going to go on to the Q&As from the videos from yesterday's video. So I have a question from Katie Booth, and they're asking, what does a constant popping in the ear mean? It's very likely that you've got a blocked eustachian tube, which I actually described slightly within the video that you just watched. So the eustachian tube is a narrow orifice that connects the middle ear, which should be full of air, to the back of the nose. And we want the air pressure in the middle ear cavity, so that's the cavity behind the eardrum, to be equal to the atmospheric air pressure. And it's the eustachian tube's job to equalize the air pressure. The eustachian tube is normally blocked, but during brief moments of yawning or swallowing or chewing, eustachian tubes, the muscles contract, and this is how this occurs at the back of the nose, causing the eustachian tube to open, and air can either gush in or out depending upon what needs to be done to equalize the air pressure. So if you've got a popping sensation, it's very likely that your eustachian tube is blocked intermittently, and when you swallow a yawn, it's trying to pop. So you can use some nasal decongestion spray, the Otavent nasal balloon, the ear popper, or if you're in the States, I think they call it Eustachi, which is the equivalent. Trying to just unblock a eustachian tube. You can use steaming therapy, so hot boiling water with menthol drops, eucalyptus crystals, towel over your head, just inhale the steam. If that doesn't improve, then obviously go to see a doctor or an audiologist who may be able to assist further. Another question from Donna Menahit. I'm sorry if I didn't pronounce that correctly. Where exactly is the opening on the eardrum? So there's no actual opening on the eardrum. I think Jennifer Taylor answered that very well, actually. So I will leave. I think there's nothing more to add to that, actually. I think she's given a good answer. There's another question from Cuts Like a Chris 26. And I think Katie Booth actually answered that question. So let's just read her answer. The first question was about trimming the hairs, and yeah, you've given a really good account there. And the second question is how prevalent is occluding ears throughout history. So I wouldn't know throughout history. What I can say is in the UK, there's about 3 million cases of earwax removal required that go to their doctor in primary care to have their ears removed, which is about 5% of the population. So if there is, I'm guessing there might be a bit of a cultural difference with earwax, but if we use 5% as a global trend, I think we're looking at, I think there's 6.6 billion people in the world, is there? So we're looking at about 30 million if my math is correct. So yeah, it's very, although it's so 5%, it doesn't seem like a large number, but 5% of a big population, a global population, is a huge amount of people. I hope that helps. There's a question from Sonia Gruz. I hope, again, I'm sorry if I'm not pronouncing the names correctly. Have you thought about making just a video Q&A? Yes, it's just extra time to do these things. So if I can incorporate it within a video, it's just a bit easier for me. But the more I'm doing them, I'm thinking I'm going to have to come up with a format whereby maybe once a week I collate all the questions and answer it in one video a week. So let's see if I can come up with some formula and some methodology of doing that. I've got a really good question from Dawn, the metal detective. Have you ever had anyone pass out in your chair? Yes, I've had 2 people, and ironically, they were both in the same week. They were young males, probably between the age of 30 and 40, and they suffered from the caloric effect, so they were performing microsuction, which got them dizzy due to the caloric effect, and they both passed out. It was only short-lived, but they become dead weight. They literally do pass out, and you just have to... one of the patients almost fell off the chair, so I had to get them stable on the chair. I managed to... so I've got a foot lift, so to lift their feet above their heart, so it just keeps the blood going back to the brain. And they were fine in the end, but yes, I have. It's very rare, but I've had it twice in a week. There's a question from Judy Hume. Have you ever had a case that you could not clear the ear? I had one where someone got an earbud trapped in the ear. They actually got a referral from another audiologist that weren't able to remove it to myself. I also wasn't able to remove it. It was just too painful for the patient. I then referred that to my colleague, Mr. Rajali, who's an ENT surgeon, because they can use local anaesthetic. But even with the local anaesthetic, the patient found it too uncomfortable. So eventually they had to have a general anaesthetic. I had another patient, a young girl who used to travel from Manchester, suffered from keratosis obturans, really, I would say grade 3 keratosis obturans. And it happens, so you remove it and it comes back, and they travel all the way to Leicester to have it removed, because in Manchester where they went, or the places they went, weren't able to. On a couple of occasions, first occasions I was able to. Third occasion, it was just too blocked, and I then referred them to a local ENT that I know in Leicester, because they're in Leicester. They also weren't able to remove it, so I think that patient, or I know they had to have a general anaesthetic again. So I think there's probably one more, but I got the patient back second time when I was able to. There's a question from Gregory Johnston. Have you ever got upset at a client that you wanted to push the Zollner suction through the eardrum? Of course not. Would never contemplate that. We had some patients who do make you feel really uncomfortable for whatever reason. But yeah, you just have to remain professional. And when that patient's on that chair, it's my priority, no matter how... Sometimes they can make you feel uncomfortable for various reasons. To do my best job, I'm just concentrating on removing that wax as comfortably as possible for that patient. So the answer to that is no. There's a question from Shaska I can't pronounce the surname, I'm so sorry, but the question is about the Cawthorn hook and my feelings on it. So the Cawthorn hook is really, really good. The problem with that, it's in metal and it's got kind of a sharp tip. And because I train people in performing earwax removal, I wouldn't feel comfortable training anyone using that device. I think it would be too early on in their careers. So I prefer using St. Bart's ear hook and Jobson Horn, the carbon fibre versions, because they're less traumatic in the ear if you do come in contact with the ear canal. But of course, and because I train people, I want to use the instrumentation that I'm going to be training other people in. I think that's only fair and right. Myself, would I feel the need of a Cawthorn hook? Probably no. If it was available in a carbon fibre material, then yes, and there's a possibility that that can happen. But my only worry is with that, the tip would be too brittle, and if you've got a hard piece of wax, and because it would be a lot thinner than the St. Bart's ear hook, it may snap off in the ear. So it's a bit difficult. I hope that helps. Just to add on that, there's another device, a carbon fibre tool called Rosen Inserter, which is probably in between a St. Bart's ear hook and a metal Cawthorn hook. So that probably has a bit more credence to use. So there's a question from Angela Crane. Can your ear canals twist and chain as we get older from birth? So yes, I discussed in this video at the beginning about the collapsed ear canal. If you have chronic infections in the ear, it can cause permanent swelling and narrowing of the ear canal, especially near the eardrum. That's called stenosis. Some people can have surface ear, or also known as exostosis, where you get bony spurs. If you have other types of like keratosis obturans, that can expand the ear canal, cause a crater widening, or chronic infections can cause craters at the bottom of the ear canal, or canal cholesteatoma. So it is possible for your ears to change shape. From birth, the ear canal is obviously a lot narrower, diameter smaller, and as we age, the ear canal just get longer and bigger. So you get a natural change in the ear canal through just the natural aging process. But infections and other causes, so as I've mentioned, some of the causes there can also change the shape of one's ear canal as we get older. So there's a comment from Phyllis Debisco about the videos, that they really enjoy it, and it's just referring to the Q&As and not doing it on all the videos. I hope the way I've done it today, so I actually read your comment and thought, because you mentioned you prefer me discussing the earwax removal itself, you find that's more engaging. So purposely on this video, I refrain from answering any questions until the end, so I'll do a complete separate Q&A. So for those people that don't want the Q&A, they can just focus on the video. So I hope this format was a bit better today. I tried to avoid answering any questions during the video, and I've left it till the end. There's a question from Claire about their son, who's 20 and seems to have runny ears, ongoing, chronic. I wouldn't be able to know what the idea is, but if you've got a runny ear, you definitely need to go and see a doctor or an ENT specialist to see, because it sounds like it may be some sort of infection. So get that checked. There's a question from Laurie. Do you have a way of putting the procedure on a big screen for the patient to watch live? Yes, there is capabilities of doing that. We can use Apple AirPlay to put it on a large monitor. I've tried that a couple of times, but patients, I find, don't enjoy watching it live because they get a bit anxious. Naturally, if you're watching someone in your ear on a big screen, and it's going to be difficult to stay still, I would have thought. So there is capabilities, but I prefer not to, or the patient also that prefers not to. And there's a question from Happy Place. Do you think I'll go back to school and complete ENT study? So for me to become an ENT specialist now, I'd have to go back to do a medical degree. I can do a postgraduate degree, that'll be 4 years. Then I'll have to do a foundation year 1 and 2 in the hospital on rotation for 2 years, so that'll be 6 years. Then you pick your speciality like ENT, and I think it's 7 years training. So we're looking 9, it'll be 14 odd years to retrain. I'm kind of really happy with what I'm doing. Mr. Rajali, who I've mentioned a few times, is an ENT consultant. He has mentioned it in the past that he feels that, it's something I should consider. But my career's taken me where I am, and I'm really, really pleased with what I'm doing. That's one thing, I think, doing a job you enjoy, and I really enjoy my job. It can be hard work, don't get me wrong, every job is, but ultimately it is something I enjoy, and I think I'm touch wood, I'm quite okay at it, so which is always a benefit. So I'll be sticking to audiology, I think. There's a question from M. Best way to prevent water getting in the ear. They currently use earplugs with an earband when swimming. So you can get custom earplugs. They're probably the best. That's where an audiologist takes a cast of your ear. So the earplug is molded for your individual ear to give it a complete tight, air, watertight seal. But it seems like what you're doing currently is quite good, using earplugs with an earband. There is some sprays you can get as a last line of defence in the UK. Earol Swim. It contains olive oil and tea tree, so the olive oil is hydrophobic. You squirt that in your ear prior to going into water. So if water does get in your ear, because the canal's coated with the oil, it's hydrophobic. The idea is the water rolls back out. And tea tree has got antimicrobial effects, so if there's any bacteria in the water that gets into the ear, the tea tree helps with it. I never ask patients to rely on that solely. I can advise them to put that in the ear and then put plugs in, so it's an added layer of defence. So I hope that answers your question. There's a question from CJ1686 about ASMR Chinese ear cleaning. So from what I know about that, in China, or is it Japan? I'm guessing it's China, if I remember correctly. There's like stalls of shops open, so people during their lunch break or after work visit these stores and they lay down and they have music playing around them and they're almost on a soft couch, and there's kind of like feathers put in the ear, stuff like that, and it helps to relax the person. So there's a lot of nerves in the ear, so as long as you're on the outer third, these can activate those nerves and people can find it enjoyable and pleasurable. So I think that's what you mean by that. And have I done a video about the tools that I use? Not yet. There's been a few questions about that in the last week or so, so I will try and get a video up on that in due course. And there's a question from Janica76 about whether I've taken photos of the wax in the suction liner, the tank. I haven't, and I think someone else commented on that. It's just because it is, let me just see what their comment was. The comment was from Suzanne Irving. It is quite underwhelming, because you can't really see much. It's just a tank. It's almost opaque, and it's just gashes of wax. It's not really something that I thought would be interesting, but maybe I'll put it up, and then people like it, I might continue. There's a question from Call Me Nancy about using hydrogen peroxide to clean up all the remnants, the residual piece of the wax. And I think Susan Irving's answered that really, really well. A bit of wax is good for you guys, so it helps to moisturise the ear. It keeps the right pH. It's a bug repellent. Suzanne's definitely been watching my videos because that's the perfect answer. There's a question from Beth Thomas about whether excessive earwax can cause a loss of smell and taste. I would say no. However, there's a nerve called the chorda tympani. Sometimes it's visible and it's just behind the eardrum. It goes past the hammer bone. That nerve connects to the anterior part of your tongue on either side. And so if there is an infection behind your eardrum, but there's no wax behind your eardrum, that can affect the chorda tympani, which can affect your taste. So it definitely won't affect smell. Can it cause a buzzing or dizziness? Yes. So sometimes earwax can lead to tinnitus, which is a noise or ringing or a buzzing noise in your ears, and it can cause vertigo on occasion. So it won't cause a loss of smell and taste, but it can lead to tinnitus and dizziness. There's a comment from B. Hathorne Barnes, but I think M and PG Pot Pie have both answered that really well, so I won't dwell on that anymore. There's a question from GS. It's more of a individual diagnosis, which I want to try and avoid. It's a long one, and I did read it. Even if I was able to answer it, would be very difficult, but yours is more of a medical query, I think, so I'm not medically trained, so I would definitely, I know you said you've had other things going on, and from what you've described, you've had a lot going on, so I totally understand that. For that reason, you haven't been to see an ENT, but I would definitely go to see an ENT more so than a doctor or an audiologist. I think yours is more of an ENT issue. It needs that higher level of medical knowledge, and I hope you can get that sorted. There's a question from Coffin Dodger. Have you ever dealt with cerebrospinal fluid leakage via the ears? I haven't, but I have come across it before, speaking to an ENT. Head trauma, I think, which is, in your case, is slightly different, I think. I have a neuro injury from a vaccine. But yes, there's been head trauma, and that's caused a leakage of the cerebrospinal fluid. And I've heard of cases where that's perforated the eardrum and the fluid's leaked out. But I personally haven't. That's probably more a thing like an ENT would see rather than an audiologist. There's a question from Darlene Flatman relating to if a patient's had surgery for cholesteatoma, can an audiologist see the patient for cleaning the debris? So quite often patients who have had a cholesteatoma, they can have a mastoid cavity. I myself do treat mastoid cavities. Not all audiologists do, but some do. So it's not out of the question. Sometimes though, with those really complex cases, as well as cleaning the ear out, they do need to have some antibiotic cream applied in the ear or some medication prescribed. So under those instances, I would definitely recommend an ENT because an audiologist like myself in the UK isn't allowed to prescribe. But if you've got a clean cavity and it's just dead skin collection with minus any ear infection, yeah, I do see quite a few. There's a question from Toy Angram. Does it help patients if they close their eyes to prevent the caloric effect from vertigo? So it works both ways. So sometimes if you close your eyes, when you've got the caloric effect, in a way you want your eyes to correct your ears and tell your brain that you're not moving. So I often ask patients to put their finger out in front of them or focus on something in the room and get their eyes focused on that particular point in the room, and then it can just tell the brain that actually you're stationary, you're not moving. Sometimes if you close your eyes, you can actually get, and I'm guessing people are different, but in my experience, patients get more dizzy because their eyes can't override their ears because your eyes are shut and you're not focusing on an object. So I would typically ask patients to keep their eyes open, but if people find the caloric effects better for them, resolved by closing their eyes, definitely just got to do what's best for that individual. So there's a question from September Moonlight. Has there ever been a patient that earwax was so bad that you couldn't do? There was 3 cases. I think I mentioned right at the beginning of the Q&A section. But yeah, there's been 3 cases. 2 that I wasn't able to do and they needed general anaesthesia. And 1 that I had to get the patient back. So I hope that answers that question. Wow. An amazing question from Alexander F. Neil, what is your favourite fact about the ear? Wow, that is a thought-provoking question, and I'm going to think about that and come back to that on another time. I need to think about it more, I think. Yeah, you stumped me there. It's a really good question, so well done. Again, another question from Alexander F. In the 70s, my mother had holes put in her eardrums to treat an infection. So I'm guessing that was... your mother must have had glue ear, an infection behind the eardrum where there's a buildup of fluid. And so what sometimes the ENT surgeons do, so this fluid would typically drain out of the eustachian tube, but the eustachian tube is blocked. This fluid can't drain and it builds up behind your eardrum. It then gets infected, it becomes viscous and it can turn into glue ear. And by using a scalpel, making an incision to the eardrum, it allows the fluid to drain, so the infection clears. And to stop the fluid from building up, again, they'll put grommets in, or ventilation tube, or T-tube. There's just different names for a grommet, which will then allow air to enter behind the eardrum via the grommet because the eustachian tube is blocked, which can't equalise the air pressure. And any fluid that builds up behind the eardrum, it can drain out of the grommet into the canal. So that's why. There's a question from Kaylin Kuntz, and again, I apologise if I'm not pronouncing these correctly. What are the reasons why wax doesn't naturally migrate? Can be several reasons. So the skin that lines the ear canal and the outer part of the eardrum, as that skin dies and sheds, it naturally moves sideways like a conveyor belt out of the ear. So that's what we call the epithelial migration. And any wax that's sitting on the surface of the skin, as the skin migrates and comes out like a conveyor belt, any wax sitting on the surface also gets expelled. So what are some of the reasons why that doesn't happen? Patients who undergo radiotherapy around the ear and the head, it does something to the skin cells where it stops migrating. So that's one plausible explanation. Sometimes at age, something happens in the cell's DNA and it just stops migrating outwards. If you've got a very bendy, twisty ear canal, as the skin is migrating and the wax is migrating, it can get trapped around the bends and corners. If you've got, and I mean excessive hair, not just a bit of hair, I mean excessive hair, that can mat against the wax, preventing the wax from coming out. If you wear hearing aids or earbuds, that can push the wax further in. If you've got a mastoid cavity or an enlargement of the ear canal, wax can get trapped there. I'm just trying to think of, if you've got very dry skin or dry wax, you get friction and the wax traps into your ear. Or if you've got very mushy, sticky wax, that sticks against the canal wall so it doesn't migrate. I think you also wanted to know what causes a mastoid cavity. So a mastoid cavity is usually a surgical cause. So the surgeon opens up the ear canal either to remove infected bone of the mastoid through glue ear, or in the removal of a cholesteatoma, they have to drill out the back of the ear canal and open up the back of the ear canal into the mastoid bone. So it's normally surgically caused. Sometimes if you have an untreated cholesteatoma, the infected cholesteatoma can start causing an enlargement and erosion of the ear canal, which can then develop into the mastoid cavity. Also, if you've got grade 4 keratosis obturans and the skin plug is really large and it expands and widens the ear canal, that can also develop into a mastoid cavity. Kelly Knight asks about what happens when you get autophony. So when you yawn and your voice sounds loud and distorted when you're not yawning, but they're at random times. So autophony is a form of occlusion. That's when your own voice gets trapped inside your head and it can't escape. What are the potential causes? It could be that you've got a blocked eustachian tube. It could be that you've got a middle ear infection. It could be that you've got earwax. Or it could be that you've got patulous eustachian tube. Or even a superior canal dehiscence. So I'll just go back to patulous eustachian tube. So the eustachian tube, as I've mentioned a couple of times in this Q&A, is the pressure equalizer in your ear. It's a tube that connects the back of the middle ear to the back of the nose. The eustachian tube is normally blocked, but during brief moments of yawning, swallowing or chewing, it opens and the air pressure changes. So the key point about that the eustachian tube is actually normally closed, it momentarily opens during moments during the course of the day. Patulous eustachian tube is when the eustachian tube is permanently open. And we don't want that, because if it's permanently open, your own voice can travel up the eustachian tube and stimulate the eardrum. And also you then hear your voice through the normal method out. So you talk, the voice goes into the ear canal. So in essence, you're hearing yourself twice, not only through the normal way where your voice gets projected out into the air around you and it enters your ear canal, but it also, if you've got a patulous eustachian tube, it travels up the eustachian tube and hits the underside of your eardrum. So your eardrum is getting activated twice by your own voice, and because it's at different times, you get a muffled autophony effect. So I hope that answers that. Yaga Kang asks, how do I feel about people stealing my videos and posting them on TikTok and YouTube? In a way, I feel privileged in a weird kind of way, because they feel the need to use my content, so they're obviously impressed by the content. But yeah, obviously it's not nice when people are stealing your content. I've had to, on a couple of occasions, report it, but if I report every single video and channel, I'll probably be busy, wrapped up all day doing it. So it's really difficult to keep on top of. But thank you for the people that do notify me that people are stealing my content. It's much appreciated. Julie Welton, I do apologise. It's not a bloody gauge, it's a gauge. That's the size of the instrument. It's just slip of the tongue sometimes. I'm just so used to saying gauge or gorge, I can't remember what I say now. But I'll try and remember your comment and make sure I pronounce it correctly in future. BZ asked how I chose a career in audiology. It kind of fell into it, so it's a bit of a longer story than that. But yeah, kind of more or less, to cut a long story short, I kind of fell into it. I wanted to become a vet, but I couldn't study locally, and I wasn't able to move to study, so I fell into audiology. And what's my favourite part of the job? I think everything. I do enjoy running my own business. I used to work for the National Health Service and then another company, private company, and being my own boss I really do enjoy, because I feel I can give my clients the best quality of care by doing things my way. And the best part of the job is just helping people. But when people come in and they can't hear and they leave and they can hear, and you can see the difference in their face and the joy and how much it can change their life. It does hammer home how important our ears are. So that's the reason, and that's the biggest pleasure I get from being an audiologist. There's a question from Josie Lancaster. So why do some professionals use a metal cylinder cone in the ear? So that's a speculum. They're normally plastic, but you can get metal ones. So if you perform ear microsuction using an ENT microscope or head loops, you insert a cone in the ear. It's called a speculum. So that's the reason why. And it's designed to just open up the ear and straighten the ear. So it's quite normal if you're performing microsuction using those techniques. With an endoscope, there is no speculum involved as yet. There's a question from Hazel Sisley about Crohn's disease. Unfortunately, it's not my area of expertise, but I do know, obviously, as you mentioned, it normally affects the gut and it can cause a reduced immune system. I really can't comment. I don't think it possibly related to your ear problems, but I don't know. So I would definitely try and seek guidance from an ENT there. I just don't want to give you the wrong advice. It's not really my expertise. Hi, Poison Ivy. Your questions about weighing the contents. Yes, I have stopped. It's just, I just don't get time, if I'm honest, sometimes. Especially at the moment, just so busy and it's one in, one out. I still got the scales. I think it might need a new battery in there, but I'll see what I can do. If there's a big haul, then I still probably will try and weigh it. But if it's less than a gram, then I know it's going to be less than a gram. I typically just avoid weighing it. But if a lot of people enjoy it, then I'll try and get back to it. Well, I think that's all the questions. So I hope you enjoyed that. I actually quite enjoyed doing the Q&As. But yeah, I think doing this every day is going to be quite challenging. Because the video itself is probably about 8 minutes and I've been probably speaking for half an hour going through those, so it does take up a lot of time. I actually do enjoy it because it keeps me on my toes in terms of my knowledge, and I actually, as you're probably aware, enjoy my job. I've got a lot of passion and I like education.